My guest today, he calls himself a mechanic of the digestive system. Karibu, Dr. Kariuki.
Well.
We're going to talk about endoscopic procedures, and weight loss. So stay around, because this is a discussion that you do not want to miss. Dr. Kariuki, it's a pleasure to have you here. Before we proceed to what has brought us here today, we'd like to know you, your services, where can we find you? The people are asking.
Very well.
Yeah.
Thank you very much, Dr. Well, as you've been told, my name is Dr. Kariuki. I work in the endoscopy unit at the Karen Hospital. I'm a trained endoscopist, and I also work in the general surgical department. My job is essentially to fix disorders of the digestive tract. As he said, I'm the mechanic of the stomach and anything to do with the digestion of the body. And therefore today I'm happy to be with you, and I'm happy to contribute to this discussion the best I can.
All right, great. So what are some of the specific services, if you don't mind just mentioning what you offer in your department?
Very well. Most of our work is minimally invasive. What simply that means is that we don't cut up people. What we do is we use keyholes, okay, or what are called natural orifices. For example, the mouth is what we use to access the body, and therefore when you leave our services, you have no scar or minimal scarring. And the procedures that we do are similar procedures to what other surgeons do across the world. But more importantly, we do them in a manner that makes sure that your recovery period is faster, and you have less pain, and you're able to resume your quality life as soon as possible. So our main job is in the digestive tract. We also do a lot of work on weight loss procedures, and we do also work on cancers and the treatment or palliation of cancers.
Oh, that's great. Yes, let's go to what has brought us here today. Endoscopy. What is this thing?
Thank you. Endoscopy is an interesting term. What that simply means is any procedure for which you put a camera into the human body. When you put in a camera, you're putting in for two reasons. One, you want to see the problem, and also you want to intervene and treat the problem.
Yeah.
So endoscopists are a wide-ranging specialty. We have those who put the camera through the nose. There are those who will put it through the mouth, and others who will put it through various other areas. In our line of work, we mostly put it through the mouth, and then we follow the digestive system through the mouth and treat all the problems of the digestive system from that access point. However, we are also able to put it directly from the abdominal wall, the stomach. So if you come in and you have a problem that requires surgery, and we are able to do this with minimal invasion by putting small cameras through small incisions in your stomach, and also treat and diagnose in the same manner that we do from the mouth.
What about downwards?
Wonderful. The human body is an excellent machine, okay? And I'm happy we are in the garage show today to talk about the machines of the human body.
Yeah.
So the human body has an entry point and an exit point. So sometimes we are forced to go through the exit point to be able to see the pathologies or problems of the lower digestive system. So we can either use the mouth or use the exit for either purposes.
All right, great. So so there is the through the mouth, through the lower part, and through the abdominal wall.
Yes.
So let's start with through the mouth. What are the common symptoms that people have that necessitate the need for endoscopy?
Well, the most common is usually abdominal pain. And the main complaint we get across the hospitals in our country and the region is what people term as ulcers or heartburn. Well, ulcers per se are a correct way of describing the problem. And what this is simply wounds on the walls of your stomach. So what happens is the stomach produces a very strong acid. The acid that is contained in the stomach is so strong, in fact, that it can digest metal. And so the stomach has evolved, or in the creation and the design of God, He created the stomach to have a very strong wall and it has very effective protective linings so that it is not digested by this very strong acid. However, there are certain problems that come which destroy these protective walls. And when they destroy the protective walls, then the acid is able to burn the stomach and create these wounds. And those are the wounds that are now known as ulcers. So the problem of ulcers is commonly misunderstood to mean excessive acid. It is very rare for you to have excessive acid. What the problem is, in fact, is that you have destroyed the protective walls of the stomach, and therefore the acid is able to create damage on the wall of the stomach because the protective linings have then been erased. Yes.
Could there be some specific habits, like maybe what we eat, that take down this protective layer?
Thank you for that. Indeed, in Africa, especially what we term as sub-Saharan Africa, the main problem is in fact an infection. And this infection, we call it Helicobacter pylori, or H. pylori in short, is in fact a bacteria that is found in our water sources and food sources. And when we eat food that is contaminated with this bacteria, it goes and lives in the stomach. And when it lives in the stomach, it burrows or creates wounds in our stomach linings. And then these wounds become larger with time, and then they eventually become large enough for the acid to start burning, and the patient comes in with pain. So interestingly, you could have a H. pylori infection from 10 years ago, and your symptoms begin today. And therefore it is important to know that our food sources and our water sources have to be extremely audited and taken care of so that we don't contract this very endemic problem of H. pylori in sub-Saharan Africa.
Wow. What about the other foods that we take? Let's say like oranges, citrus fruits, alcohol.
Now, in terms of food and alcohol, those ones are what are called triggering factors. Remember, if you have a wound there, as long as there's no acidity in your stomach, you're unlikely to develop any pain from that wound. But then there are certain foods that we take that trigger acid production or more acid production than is usual. And these are the foods that then will trigger the symptoms. So the orange or the beans or a meal of sukuma wiki in itself is not a problem. But because there are ulcers in the stomach, and because the sukuma wiki or the beans will require more acid to digest, then the problem of pain comes. Because then more acid than usual is produced to digest these specific types of food. And because there are ulcers there, this acid meets those ulcers, burns the ulcers, and the patient feels the pain. However, there are certain drugs that will create these wounds. And these are especially painkillers. The common painkillers that we use, like aspirin, diclofenac, ibuprofen, they belong to a class of medications we call NSAIDs. Now, these drugs are commonly used by the elderly fellows, older people in our society with chronic pain, for example, those who are suffering from arthritis. And when they use this for a long time, they actually end up doing the same things that H. pylori does. So they create wounds in the stomach, and then those wounds get burnt, and the patient comes in with pain.
All right. That's interesting. So let's take alcohol for example, because on its own there's no danger with it.
Yes, indeed. If your stomach walls were protected and there was nothing that destroyed the protection, and therefore you did not have these ulcers, if you took alcohol, you are unlikely to develop stomach pain. Okay? However, if you take excessive alcohol, you lower the overall immunity of the body. And therefore, infections such as H. pylori have a better chance at infecting you, because overall the body becomes weaker and you're not able to fight these infections, and therefore you're not able to develop resistance, and therefore you get these complications, including the ulcerations in the stomach.
All right. And that is one symptom that necessitates the need for endoscopy. So we can keep the conversation there. What are other symptoms necessitate the need for endoscopy?
Yes. So the first one and the most common, as we say, is pain. What people describe either as acidity or heartburn. The other common symptom that brings people to the hospital is difficulty in swallowing. Now that one is not a good sign. When you are expressing difficulty in swallowing, it means that the digestive system or the food pipe, basically the conduit that transports food from your mouth to the stomach, has a blockage. Most of the time, the blockage is not cancer. But there are some times when the blockage can result from cancer. And therefore, it is extremely important that if one is experiencing difficulty in swallowing, they will need to have an endoscopy done so that we can be able to quickly find out the reason why you are not able to swallow properly and then treat as appropriate as possible and as quickly as possible. Okay. The other symptom that will bring people commonly to the hospital seeking endoscopy is what are called regurgitation. In our common language, people call it the heartburn. In Kiswahili, I don't know, the term that is commonly used is kiungulia. Okay. You say, when I take a plate of beans, I get a lot of heartburn. Okay, I get a lot of kiungulia. That is a common problem in our region, and the main reason for that is that the junction between the food pipe and the stomach, where the food pipe meets the stomach, that junction naturally should be tight, so that when food arrives in the stomach, it can stay down in the stomach and doesn't come up. But if the junction becomes loose, then you get this heartburn. You get these symptoms of heartburn because both the food and the acid that is supposed to digest the food both come up. And they come into the food pipe, and the food pipe travels through the chest, so you feel pain in the chest.
Because the contents are coming back up.
Yes, indeed. And some people, it is so severe, they even develop throat pain, and they develop changes in the voice. They have hoarse voice. And the reason is, of course, that the acid has come up so much high that it is now irritating the throat and giving you the hoarseness of voice. And that is not a good sign at all. Yes.
I think this is something that is quite common among people. We might want to do a little more details there. What are some of the things that predispose people to kiungulia? Now there are those factors that we call you're not able to prevent them, okay? And there are those that are preventable. So we have non-preventable and preventable factors. The non-preventable factor that is most common is old age. Old age. Okay.
The older we become, the less strong we are physically, and even the tightness of our junctions, like the junction between the food pipe and the stomach, becomes less tight, and therefore food is able to pass by and come back up into the food pipe. Okay. There are other problems, we call them connective tissue diseases that people are born with, in which their tissues are naturally not tight, and that can also bring the problem. However, a majority of the time, we have what are called preventable factors, things which if we changed our diet and our lifestyle, we can be able to change and completely clear the problem. One of them is our dietary habits. Normally we are cultured to eat 3 square meals a day. So you take a big breakfast, and then you starve until lunchtime, you take a big lunch, and then you wait for supper to take another lunch. Supper. Now, it is not right. You are indeed supposed to take small, frequent meals. So if you're able to take a small breakfast, a snack in between breakfast and lunch, a small lunch, a snack in between lunch and dinner, and then a small dinner, then you're not overloading the stomach. And therefore the food content in the stomach is not able then to come back up. The other thing is water intake. We see a lot of fellows in the office carrying water bottles and telling everybody that they take lots of water. But in fact, the water should be taken with meals. We do recommend that when you're taking your lunch, you take with 2 large glasses of water. Similarly, when you take your supper, you take with 2 large glasses of water. So this water should be taken intermittently, not continuously, and it should be taken with meals because it also helps to wash down the meal and keep the meal down in the stomach. In terms of lifestyle, we have certain practices that also predispose us to kiungulia or heartburn. For example, when we go to sleep at night, if we are going to sleep on a flat bed, that ideally would erase the need for gravity to push the food down in your body. So we need to have beds which are elevated, beds which have pillows, so that the level of our food pipe is above the stomach. And therefore when we are swallowing, whether it is food or saliva, the food can be kept down by gravity and doesn't need to come back up. The other thing that you need to do in terms of lifestyle change is when you take your last meal before bedtime, it should be at least 3 hours before you go to sleep. Those of us who take a large meal and then end up in bed within minutes, we are in fact risking ourselves to get the kiungulia or heartburn.
Right.
So we need to take our last meal at least 3 hours before bedtime. Remember to take with lots of water and then give it time for it to digest before you end up in bed. Okay.
All right.
Lastly, on lifestyle, we have to prevent certain practices like smoking. If you smoke cigarettes, you make all your tissues very loose. And as I said, the junction between your stomach and the food pipe should be tight to keep the food down. So those of us who smoke, we are also risking heartburn because the junction becomes less tight and food is then able to come back up and burn us in our chest and cause us the heartburn symptoms.
We need to take a pause, and when we're back we will continue with the common symptoms that make us to go to hospital and possibly get an endoscopy. Stay tuned.
You are watching TV 47, the home of untold stories.
Mount Kenya University takes pride in being an academic giant with some of the best infrastructure, imparting knowledge to the best brains in the country and the region. Our members of faculty are keen to deliver market-driven programs in science and humanities with a keen focus on linkages with relevant organizations. Join us today and train with the best to become the best. Mount Kenya University, unlocking infinite possibilities.
You are watching TV 47, the home of untold stories.
Welcome back. We are continuing the conversation on endoscopy, colonoscopy, and weight loss. So we are done with the symptoms that necessitate the need for endoscopy. Let's talk about the symptoms that necessitate the need for a colonoscopy. First of all, I didn't think, did we talk about what colonoscopy is? Maybe you can mention that and now what necessitates the need for that.
Thank you, Doc. So as I said earlier, we are mechanics that deal with the digestive tract. The word endoscopy, in fact, means to check with a camera in the body. And therefore that can be for the upper part and the lower part. Now there are specific terminologies we use or names that we use for the upper part, that we call upper GI endoscopy, and the lower part, which we call colonoscopy. So these two are in fact endoscopy, but most people relate endoscopy to mean the upper part.
Yeah.
Okay. Now colonoscopy is a very important test. It is a diagnostic method that is now determined to be essential for anyone above the age of 55. If you are above the age of 55, it is now strongly recommended that you do a colonoscopy once every 10 years. And the reason being is that we have seen increased cases of people coming in with what are called colorectal cancers. These are cancers of the large intestine. The main reason why people get this cancer is diet. Those of us who have been taking red meat for a long time, those of us who also have been taking a lot of spices for a long time in their life, And processed foods, especially processed grain, those are risks that can give you cancers of the large intestine.
Yeah.
Now, the symptoms that will present, or what will bring the patient to the hospital and eventually lead them to having a colonoscopy, the most common is constipation.
Yeah.
Now, a lot of people believe that theirs is a natural thing. Some people you talk to and they'll tell you, my stools are naturally hard. I go to the toilet once a week, and it has been like that for a long time, so it is normal. It is not normal. It is an abnormality that you have learned to live with. So constipation should always be investigated. The main reason why people get constipated is food. The amount and the quantity and quality of food that they take determines a lot about how they pass the food down through the exit. But that is not the only reason. The ominous reason could be that there is something growing in your intestine and it is in fact blocking the passage of that food. Now, as a doctor, those are the things we are more interested in. Because if there is blockage, that blockage might as well be cancer. And if we are able to catch it quickly and early, then it is treatable. But if we don't catch it early, then there will be big problems. So anyone with constipation, I encourage them to get checked, and especially so if they're above the age of 55, they will need ideally to have a colonoscopy done once every 10 years to make sure we have nothing that is dangerous within their large intestines.
Great. Let's move on to something else now. So I have maybe problem with let's say the gastritis. That's the common word.
Yes.
So I've come to see you, and you've recommended endoscopy. Walk me through the journey.
Wonderful.
Yeah.
Before that, let me just speak about other symptoms that can lead one to get a colonoscopy. We've said the most common is constipation. The other common one is bleeding.
Yeah.
Some people will go to the toilet, and after finishing their business in the toilet, they will notice either some blood in their stool or some blood when wiping. That is also not a good sign. That is a sign either of problems of constipation or even more ominous problems, including cancers. So anyone who has blood in their stool should always come in for an assessment and ideally have a colonoscopy done. The other common reason is the swellings that some people have in their exit regions. If you have some swellings in your exit region, what we call hemorrhoids, there could be innocent hemorrhoids because of long or what we call chronic constipation for a long time, but there also could be signs of other problems in your large intestines. And therefore those of us with hemorrhoids, even if you've been treated for hemorrhoids in another facility or earlier, and you still have problems of hemorrhoids today, it is important that you have a colonoscopy done. And the good thing about colonoscopies, as we said, is that they're done once in 10 years, and they are extremely important, especially for those above the age of 55. I cannot overemphasize that enough. Yes.
Great. Wow. All right. Now let's talk about the journey. You have seen me. You have recommended an endoscopy. How is my journey going to be?
Wonderful. Thank you for that question. So endoscopy is a fun, painless procedure. There are those myths that come with people, and people sometimes associate endoscopy with either a lot of risk involved or a lot of discomfort involved. But the journey towards getting an endoscopy should be fun, should be event-free, and it should be convenient to the patient. When you come and see us in the clinic, and we get an assessment done on you, and we discover that you have those symptoms and signs that may necessitate you to get an endoscopy, the first thing that we do is we counsel you on the procedure and how it should be done. Endoscopy per se is done within 10 to 30 minutes. So once you are done, it takes another 1 hour to recover, and within 1.5 hours, you should be able to walk back home with your diagnosis and a treatment plan. On the day of endoscopy, we do recommend that you don't take breakfast from midnight the day before. The reason being, we don't want your stomach to have any food. Remember, we are looking at your stomach using a camera. We are trying to find out whether there is something growing within the walls of the stomach that can be dangerous. So if there is a bit of bread there, a bit of Weetabix there from your breakfast, it will cover some of these problems and we are not able to see clearly. The other main reason why we tell people not to eat in the morning is because once I put my camera in, some of that food can be able to come back up through the food pipe and go into the windpipe or where we use to breathe, and that is called aspiration, and that can be a dangerous issue. So we tell patients not to eat anything from midnight for those two main purposes, to help us see the stomach well, and also to make sure that we don't have any aspiration or inhalation or bringing up the food back from the stomach and into the windpipe. Okay. If you are going to do a colonoscopy in the same sitting, there will be some preparations. The preparations are done the day before. So we give you some medications that clean your food, your digestive system completely. So we remove all the food from your digestive system and make it as clean as possible. Because when we do the camera, when we put in the camera through the colon or the large intestine, the same thing we are trying to do with the stomach. We are trying to see a clean colon, so that if there is anything growing, we are able to pick it up quickly and remove it without any problems. But if there is a lot of food in there, we are not able to see much, and therefore we will not be able to be sure that whether it was a normal colonoscopy or there were problems that we were not able to see. This medication ideally is given the day before, and when we give this medication, we warn you that all the food will come out. And therefore you have to be in a nice place, either in your home or within our facility, where you have the modern conveniences. Okay? We wouldn't want to give you this medicine and then send you for a meeting, because then there will be problems. Okay? So when you come in on the day of the procedure, of course we take what is called an informed consent. The same thing we told you the day before. All the steps that we will be doing, we'll again explain to you on the morning of the procedure. And then there will be a document that you sign. By signing the document, you will have told us that you have understood every aspect of this procedure and you are completely comfortable to go ahead. So we never go ahead unless you are completely comfortable and fully knowledgeable about the procedure. Now when you come into the endoscopy suite, the first thing we do is we check your blood pressure, we check your oxygen levels, we check how well you're breathing, and then most importantly, we give you some medications to relax. So when you are in the endoscopy suite, you are unlikely to feel any pain during the procedure because we give you proper pain medication. You're unlikely to feel any discomfort because we give you proper medication to relieve anxiety. And you're unlikely to remember much of what happened. So we give you some medication that will make you not remember the discomfort of having a pipe go through your mouth or through the exit. So most of our patients, in fact all our patients, when they come out of endoscopy, they are as good as when they came in. There will be no pain, there will be no discomfort, and more importantly, there will be no memories of the discomfort. Okay? Now, as I say, the procedure takes about half an hour. The upper part will take about 10 minutes. The lower part will take about 20 minutes. And then it will take another 1 hour for you to recover. And within 1.5 hours, you'll be given your breakfast. You will get all your results explained to. And then you are sent home on the same day. So if you have an afternoon meeting, you can be able to attend it.
All right. So let's move on and talk about the procedures that you do under endoscopy. Maybe it's called endoscopic procedures, right?
Yes.
What are some of these different things that you do?
So the first and most important thing is diagnosis. When we take our camera through your digestive system, we are looking for the problem.
Yeah.
So the most important thing is identifying the problem. And when we identify the problem, we take photographs. So when you wake up, we in fact show you the photographs of your food pipe, your throat, your stomach, all the way to your intestines. And we can tell you from the photograph where exactly the problem is. Once we identify the problem, we are also able to treat the problem. So the machine that takes the photographs is also able to treat that problem. For example, if there is a growth, and this growth looks suspicious, and we think this could be cancer, we don't just take a photo and leave. We can in fact remove that growth there. So we remove the growth, and we take it to the lab, and we test it, and within a week's time, we are 100% sure what that was. If there was an area that was narrowed, for example, those who come in and say they're not able to swallow properly these days, they take a chunk of ugali and it's not going nicely down, then we are able to see where exactly in the food pipe is the narrowing. And if we find the narrowing, we are not only able to take samples from where it is narrowed, but you are able to open up the narrowing, so that by the time you leave, you can go and enjoy your ugali as you wait for the test results. Some of the procedures we do are called stenting. For some people who unfortunately have cancers, some of this cancer grows and blocks the digestive system. So you find these people are not able to eat. You eat something, it has to come back up because there is a complete blockage. Those patients, when we do the endoscopy, we are able to put a metallic stent. A stent is like a tunnel through the blockage. So you're able to tunnel through the blockage and put a metallic stent that remains there and keeps the food pipe open, so that even as you are undergoing treatment for this cancer, you are able to eat and you are able to return your strength. Okay. The other procedures sometimes
We can take a pause. We take a break and we will be back to continue with this conversation.
Very well.
You are watching TV 47, the home of untold stories. Welcome to the Mwai Kibaki Convention Center, the premier events venue. Our state-of-the-art facilities are designed to meet all your needs, from large-scale conferences to intimate meetings and everything in between. Located in the heart of Thika, the Mwai Kibaki Convention Center offers stunning views of the city skyline and is easily accessible from all major transportation hubs. Our facility features ample parking, free Wi-Fi, advanced audiovisual equipment, and our technical team is always on hand to ensure your event runs smoothly and seamlessly. Don't take our word for it. Make your next event unforgettable at the Mwai Kibaki Convention Center. Contact us today for bookings and reservations. Email multimedia@mku.ac.ke or call us on 0708 212204 or 0727 441733 or 0721 438 629 to learn more about our services and book your event.
Tonight,
wewe wacha kujisumbua na maandamano, jipange 2027.
Stop planning chaos and prepare for the 2027 election. President William Ruto tells Raila Odinga.
Na siku hiyo nitakuwa nimejipanga zaidi.
Ruto says he will still beat Raila Odinga as he did in the last election.
Mtu haribu mali ya watu ati ndio tuketi. Inawezekana?
Dialogue? No. DP Gachagua and Raila declare.
Kenya Kwanza has continued to claim that all we are looking for is a handshake. We emphatically refute these unfounded rumors.
This as Raila accuses Gachagua of planning to sabotage Azimio demos. Plus, a bloated government, 50 CAS sworn into office despite a case challenging the same.
I, Dennis Njue Itumbi.
This as Raila accuses the president of violating the law. And Kenya on high alert
following Marburg outbreak in Tanzania.
Madereva tuna hofu kubwa sana juu sisi ndio tunabeba watu wengi.
Drivers at the Namanga border post express concerns over lack of surveillance at the border.
You are watching TV 47, the home of untold stories.
Alright, welcome back. We continue the conversation. We are talking about the endoscopic procedures, and Dr. Kariuki is continuing to educate us. You had mentioned about the diagnostic and the staining endoscopic procedures. Yes.
Yeah. Essentially, I was describing what we do for those patients who unfortunately have complete blockage. These are patients who sometimes come because of cancer that has grown and has blocked their food pipe or their digestive system to the point that they are not able to eat. And so they become very sick and become very weak with time. Now these patients, we offer a unique therapy we call endoscopic stenting. So what we do in this case is we tunnel through the blockage and we put in a metallic or otherwise pipe through this blockage, and then these patients are then able to eat. And when they're able to eat, then they're able to better tolerate treatment for cancer. And so a lot of our patients who have cancer end up becoming very weak, not necessarily because of the cancer or because of the chemotherapy, but because they're not eating. And the reason is they cannot retain anything. They eat a bit and the food just comes back up. So that is a unique therapy that we offer here. And sometimes, instead of just putting a stent, we sometimes do what is called endoscopic ballooning, where we go in through the same obstruction, but instead of leaving a metal pipe, we instead inflate a balloon, open up the place, and then do what is called serial balloon dilatations, which means every other time, either every 6 months or 3 months, they come in and we repeat the same just to keep the food pipe open for them to eat. This is done for those undergoing treatment, either for curative purposes, they want to get cured of this cancer, or even for those ones whose cancer has spread so much and they're not able to access cure, but in their final days, they are afforded the opportunity to eat and become strong, even as they prepare for the end.
Correct. So you mentioned about the weight loss, right?
Yes.
Do we have endoscopic procedures that cover the weight loss?
Wonderful. That is in fact an emerging issue in our country and region. What I can say with confidence is that Kenya is leading in the region when it comes to what are called weight loss procedures or interventions. Now, amongst the weight loss interventions that exist, the most cutting edge and the one that is least invasive and the one that gives us the better outcomes is in fact what we call endoscopic intragastric balloon therapy. Big term, but what simply that means is we use the endoscopy machine to put a balloon in your stomach. And this balloon stays in your stomach for 6 months, and in those 6 months, your stomach always feels full. So you're not able to eat much. And if you're not eating much, then your weight continues to reduce with time. And we have seen wonderful outcomes in these procedures. We have seen patients lose up to 30 kilograms in 6 months. An average of 24 kilograms, which is about 4 kilograms every month. That is an important intervention. And we are able to do it extremely safely at our hospital. And we do it a lot of times, almost on a weekly basis. and majority of our patients respond very well to endoscopic balloon therapy.
All right. Will somebody who has high blood pressure, diabetes, be able to get this balloon?
Wonderful. In fact, blood pressure and diabetes are caused by excessive weight. So these are the perfect candidates for intragastric balloon therapy. However, it is important that we have to be careful when assessing these patients. Your blood sugars need to be well controlled for 3 months before taking the balloon therapy. That way, we are sure about your discipline and you are sure about your sugar control levels. Your blood pressures, similarly, for the last month before the balloon therapy need to be optimized. So when we come for this balloon therapy, you are likely to be seen by more than just the surgeon. You are likely to be seen by the nutritionist, the physician who deals with blood pressure and diabetes. You are likely to be seen by the cardiologist to have a look at your heart. You are likely also to be seen by the physiotherapist, the one who will take you through a rigorous exercise regime, because exercise is also an integral part of weight loss. And even when you have the balloon, you don't sit pretty in your house and expect to lose weight. We also put you in an exercise routine for the next 6 months, and we follow through every week to make sure you are adherent so that you can maximize the benefits of balloon therapy.
That's good. So that's one. There are other options of weight loss. Do they exist?
Yes. There are many other interventions that can result in weight loss. I would put this in 2 categories. There are those interventions you can do without the doctor, and there are those that must involve the doctor. The ones that are done without the doctor are the obvious ones, the ones that we must do every day of our lives in order to live long and healthy. Eat right. Okay? Eat right means you eat the right quantities and the right quality. Okay? A lot of our diet these days, unfortunately, is processed foods. Little wonder why our grandparents are outliving us. Our grandparents are in fact burying us these days. And that is not right. The lessons to be learned are found in the villages. They are found with the nuts, they are found with the green leafy vegetables, they are found with the natural foods. I think the ground is the best doctor that exists for weight loss. Anything that comes naturally from the ground is good enough for your health. So eating right in terms of quality and quantity is the first and most important thing. The second most important thing is physical fitness. We must exercise. And exercise doesn't mean that we go and lift the heaviest weights in the gym. It doesn't mean that we must race with Eliud and beat his below 2 hour record. It simply means that we keep ourselves busy on physical exertion activities. For example, if you are able to walk to the shop, please don't order. Don't ask for the rider to bring you the food in the house. Take a walk. If you are able to climb a flight of stairs, don't take the lift. Okay? Simple, small things that contribute to physical fitness. Okay? And these are things that can be done naturally. If you, for example, you are able to go to church on foot, why take the car? If you are able to get to the office on foot, why take the vehicle? Why take the public transport facility? Please walk. Okay? These are the things that if we were to do more, we would see less of these weight problems in our country, and we would have probably less work as doctors, but a healthier nation overall.
So folks, we've come to the end of our discussion, and our gastro mechanic is gracious enough to let us into his garage. He's going to show us what he does day to day in his nice garage. So join us as we get some demonstrations, some good demonstrations.
Very well, guys. Welcome to the endoscopy unit at Karen Hospital. My name is Dr. Kariuki. I'm happy to be hosted here by my good friend, Dr. Cheps. This is the endoscopy machine that we normally use for our procedures. And it has different parts, but I just want us to look at how we do it. So normally we have this is the endoscope itself, the one that goes in and does the diagnostics as well as the therapeutic procedures. And normally we have a nice lamp, a nice light there. This is the light that shows us the way, and then we are able to do it. So technically this is exactly what we do every day here in our endoscopy unit, Dr.
Yeah. So let me see. This is the light.
Yes, that's the light source there.
The camera needs light.
Yes, indeed. So if you see, if I put my finger and you see the screen, you can see how the light is. So this is exactly how we see the intestines. If you are looking at the screen, so we move slowly through the intestine as we look at the walls and see what is there for us to see. Okay, that is endoscopy 101, looking and diagnosing. Okay, so in this case I'll be maneuvering my camera while the patient is lying on bed, and then we are able to see everything. Yeah.
All right. So as you do that, any other thing that you might be doing?
For sure. As we said, we are both able to see, so say we are seeing the problem on the screen, and maybe there's a growth somewhere that we need to pick. Say that thumb there of mine is now the growth.
This one,
yes. Say that is the growth. So then I'll take this equipment, which is the biopsy forceps, and with this equipment I'm able to go in and actually pinch a part of that growth, and then able to take the sample to the lab for testing. Yeah, so we are both able to see the problem and also remove samples or remove the entire growth using this equipment.
all right. Could you just demonstrate at the tip how it?
Very well, indeed. Okay, so this equipment we call a biopsy forceps. At the tip, it has something like a crocodile mouth. I don't know whether you guys are able to see clearly. Okay, so that is the crocodile mouth. So when we go in, we see where the problem is. We open the tip, and then we are able to pinch and remove the stuff. Okay, yeah. So that is exactly what we do. We open and then we pinch and remove the stuff. So how I'm
controlling it from?
Yes, and I'm controlling it from here for sure. So opening and closing to pinch the stuff and take the samples.
All right.
Okay.
Right.
Yeah.
All right. So if you don't mind just showing us the other parts of the machine.
So this machine is quite technical and simple at the same time. The main business of the machine is diagnosis. And so this system, the endoscope itself, is this system. It is basically the tube with the camera at the end that we take through the digestive system and we look around. Okay.
And that is where you control.
And this is the controls. So I'm able to go up and down if I wish. I'm able to go side to side if I wish. Okay. So side to side, up and down, all over the place, so that we don't miss any issues when we're doing the endoscopy. The machine basically has a screen for us to check what is going on. Okay. It has a printer, so that everything that we take, the photographs, you can able to print with the printer. We have the computer system. This is the computer system that processes all these images. And then this is the lighting source, the source of light, the one that gives us the light that then illuminates our path when you're doing the endoscopy. Okay. We also have other adjunct equipment like a suction to remove excess water, and something else to bring in water to wash out some place, which we need to look at carefully. Yeah.
All right.
Good.
That's kind of interesting.
Yeah. Let me just demonstrate this biopsy so that I can show you how we take our biopsies. So normally this thing, the biopsy forceps, it goes in through this hole in the scope. Okay. So it goes in and in and in. and you see it coming out from the tip. There you go. So then you are then able, seeing the lesion, like if this is the lesion, you see now my tip is there, okay. Then now I'm able to open, okay. Yes. So say my thumb was a tumor, was a cancer. So I can come in, open, pinch the cancer, and then I pull the cancer out. Okay. So I come in, I open the tip, and then I take the cancer, I pinch it, and then I pull it out. So that is how we treat. Okay, in brief. So once again we go in, see the cancer, open the tip, then we bite the cancer, okay, and then we pull it out. So we pull out the cancer. Beautiful stuff.
All right.
Yeah.
Thank you so much for the demonstration. I hope we have had some practical bit of it.
Yeah.
Enjoyable. So
very well.
Thank you so much. I think we've come to the close of our show today.
Yeah.
Thank you, Dr. Karuki, for educating us and for your time.
Very well.
And thank you to the viewers.